Thank you so much, Emily, and welcome everyone. It is very nice to see so many people here, and I hope that we have an enjoyable 90 minutes together. So just to start out a little bit of an introduction, my name's Sandy Capaldi. I'm a psychologist at the Center for the Treatment and Study of Anxiety at University of Pennsylvania. I've actually been at the CTSA since 2007, but my work with trauma and PTSD began 20 years ago in 2001 when I was placed by my master's program at Women Organized Against Rape and became a rape crisis counselor here in Philadelphia. I hadn't had an interest in trauma prior to that. I was just kind of placed there. But my experiences that year showed me that this is really what I wanted to dedicate my career to. So after I finished that clinical placement at WAR, I was offered a position and I worked there until 2007 while I was getting my doctorate. And during my time there, Dr. Edna Foa, who is a world-renowned PTSD expert at University of Penn, she was conducting a research study with WAR, and I was trained as a study therapist to provide prolonged exposure therapy for PTSD. And this was another life-changing event for me because I saw how this treatment changed the lives of my clients. So I did as much as I could to be involved in that work. And eventually, after I got my doctorate, I started working at Dr. Foa's center, which is where I am now. I've spent the last 14 years there, working clinically and in research with trauma, PTSD, and other anxiety and related disorders. Now, a lot has changed in the way that we think about trauma since that first day that I walked into WAR's offices, which actually was September 11th, 2001. So it was a very weird day to start working there to begin with. But today our goal is to talk about trauma, what is trauma, talk about post-traumatic stress disorder, and to talk about effective treatment for PTSD. So we'll start with this idea of what is trauma. So the word trauma can encompass lots of different kinds of events. In this word cloud, you can see there's a bunch of different types of traumas represented, but it's certainly not an exhaustive list, right? Not exclusively these kinds of events. So let's take a minute to think about what the definition of a trauma is, okay? So the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, details the criteria for all of our recognized mental health diagnoses, right? And they've specified a definition of trauma based on the event's likelihood to result in PTSD symptoms. So according to the DSM-5, a trauma is any event that causes death, serious injury, or sexual violation, or leaves a person fearing that those things will happen. What does that mean exactly? Well, it means that the person's experience of the event determines whether or not it is considered to be a trauma. Let's look at an example. So let's say you have two people in a bank. Someone comes in with a gun and demands that the teller empty their drawers and gives them all the money that they have. Now, one person sees this happening, sees the gun, and immediately panics, thinking they're likely to be killed. Another person sees the same thing, they're in the same place, but they're very calm about it. And, they may think to themselves, this person isn't after me or my money, they want the bank's money. And they never feel any fear that anything bad's going to happen to them personally. So in this example, the bank robbery would be a trauma for the person who thought that they might be killed, and it would not be a trauma for the person who wasn't afraid that anything bad would happen to them. So the bottom line is that the circumstances of the event, what actually happened, that's not as important as the person's experience of the event. And if that experience leaves them afraid that they will be killed or seriously injured or sexually violated, it's a trauma, at least according to the DSM-5 definition. Now, another feature of the definition of trauma in the DSM-5 is the way in which trauma can be encountered. So the DSM lists 4 ways to experience trauma that are likely to result in PTSD symptoms. First, directly experiencing the event yourself. That one's easy to understand. The second is by witnessing the event occur to someone else, like witnessing a fatal car accident, for example, or witnessing someone being killed. The third way is to learn that the traumatic event happened to someone very close to you. An example of this might be a mother answering a knock on the door and being told that her son had been murdered, let's say. Now, note that here in this example, the person has to be a close friend or family member, and the event has to be violent or accidental. Now, finally, the last way to experience a trauma is by being repeatedly confronted with extreme details of traumatic events through the workplace. An example of this, there was a Facebook content moderator several years ago whose job was to filter out inappropriate content from getting through to our news feeds. And she was suing Facebook, saying that she developed PTSD from repeatedly having to watch extreme violence, death, etc., as part of her job. Okay. So that's one kind of an example. Another kind of example could be first responders or EMTs. Again, through their work, they are dealing with traumatic events on a regular basis. Okay. Now, the definition that the DSM gives us isn't the only definition in town. Okay, there's other definitions. The International Classification of Mental and Behavioral Disorders also has its own definition. So the DSM-5 is a US-based publication. The ICD is worldwide. You can kind of think of it as like the difference between the CDC here in the US and the World Health Organization that is, global. Now, the last version of the ICD was published in 1990. And in that publication, trauma was defined as any stressful event or situation, either brief or long lasting, of exceptionally threatening or catastrophic nature, which would be likely to cause pervasive distress in almost anyone. Now, the next edition of this publication, the ICD-11, has already been written, but hasn't been adopted yet. It's going to be adopted in 2022. And that definition of trauma has been modified to much more simply a threatening or horrific event or series of events. So while both of these definitions are less specific than the DSM-5, they share one similarity at least. They all focus on the idea of threat or perceived threat of harm. And again, I believe that the reason for this is because those types of events are designed to guide clinicians in making diagnoses of PTSD. And that's what these publications are about, diagnoses, right? But there can be other types of events that may lead to PTSD and other types of events that we think of as traumatic that may not lead to PTSD, but may lead to other kinds of problems or difficulties. So let's talk about some of the other ways to categorize or describe trauma. Some of these may align nicely with the definitions we've just discussed, and some may not. One way to think about trauma is related to amount or frequency. So for example, the term acute trauma can be used to talk about a single incident event like a bank robbery, right? Whereas the term chronic trauma can be used to describe repeated exposure to traumas like child sexual abuse, domestic violence, even combat trauma. You may have heard the term complex trauma before. This term is used to describe the effects of chronic trauma, especially when a person is suffering with severe and intense difficulties in interpersonal relationships. Another term you may have heard before is secondary trauma or vicarious traumatization. Secondary trauma is when a person develops trauma-related symptoms in response to helping trauma survivors, right? So ostensibly, this could be things that we might experience by helping trauma survivors, right? Some of these secondary trauma symptoms. Now, some other ways to think about trauma include medical trauma. Sometimes we don't always think about that as a potential trauma, but when someone has a really scary experience with a medical procedure or receives a terminal diagnosis, that can be traumatic. Refugee trauma is another term, which can be used to define trauma that's experienced by individuals who are persecuted or displaced, or even experiencing hardships during the resettlement process. We can also think of trauma as historical, meaning the trauma that has been compounded in the past and experienced by specific cultural or ethnic groups, like Native Americans or African Americans. There's also the concept of racial or ethnic trauma, where a person directly experiences racist-related events like microaggressions, assaults, systemic oppression. Both of these descriptions of trauma are trying to incorporate the idea of the impact of chronic levels of stress and distress associated with belonging to racial, ethnic, or cultural groups that experience discrimination. Another way to think about trauma that I'll highlight here for us today is minority stress or trauma. This is when a person is targeted based on their membership in a stigmatized minority group. It can also include that everyday chronic stress associated with being discriminated against. And these are really just a few ways to describe different types of trauma. There can certainly be other ways to conceptualize trauma. But now that we've looked at some of these descriptions and categorizations, let's take a look at some of the effects of trauma. So first, it may seem pretty obvious that trauma can affect how a person feels. But I think it's a little bit less well known that trauma can also affect our physical health and our bodies. People who experience trauma have a higher risk of developing medical problems like high blood pressure, heart disease. Okay? And they're also more susceptible to infections and autoimmune disorders. And then it sort of seems a little like, why? How does trauma do that? Well, it's likely a combination of both biological and psychological factors. For example, we know that experiencing trauma can cause neurochemical changes in the brain. And those neurochemical changes may create vulnerabilities for certain medical problems, as well as affect behavior. So some of those behavior effects may be, trying to avoid or escape memories of the trauma, which may result in risky behaviors like drinking, smoking, drug use, overeating, right? All of these kinds of behaviors that can also lead to health problems. So there's two different paths, two different ways that can happen. Another explanation is that individuals who experience trauma may have stronger and kind of more frequent surges of adrenaline than someone with no trauma history. And that can cause inflammation, wear and tear on the body. And that's also been associated with a wide range of different kinds of illnesses like cardiovascular disease and autoimmune diseases. Okay. So trauma, as we said, not only affects the body, but also affects the mind, right? And these effects may be a little bit more familiar to us. Possibly the easiest way to explain the bulk of the changes that happen is to think about how trauma changes our thoughts and beliefs. So the experience of trauma can change how we see ourselves. We start to believe that we're incapable of doing things well or of handling stressful situations. Our views about the world can shift. We may believe the world is completely and utterly dangerous at all times, and that no one can be trusted. Even our beliefs about the future can change. We may believe that things are never going to be the same for us, and that, life is hopeless. We have nothing to live for. Now, another way to look at the effects of trauma are to look at the reactions that we commonly see in trauma survivors. While there are certainly differences between people and how they react to trauma, there's many commonalities in the reactions that survivors have, even when they've experienced very different types of traumas, which is interesting as well. So some of the emotional reactions that we see after experiencing trauma: sadness, anger, shock or denial, fear, anxiety, irritability, shame, even grief. Okay? These emotional reactions can lead to different effects like nightmares, trouble in interpersonal relationships, emotional outbursts, hyper-alertness or awareness, and avoidance of trauma reminders or triggers. Survivors will also often experience physical symptoms like nausea, dizziness, trouble sleeping, changes in appetite, either overeating or not eating as much, undereating, headaches, chronic tiredness, right? All of these kinds of physical changes as well. And while PTSD is one of the potential psychological diagnoses that may develop after a trauma, people also commonly experience depression, other anxiety disorders like panic disorder, dissociative disorders, and substance use problems. So let's talk a little bit more about PTSD, which can certainly be debilitating and chronic, even a lifelong issue if it's left untreated. So we'll take a look at the diagnostic criteria for PTSD as set forth in the DSM-5. And to make a diagnosis of PTSD, a trauma survivor has to meet sort of 8 overarching criteria, and they're labeled A through H. Okay? So we'll start with criterion A, which is that definition of a trauma that we discussed a few minutes ago. Right? So to review, the person needs to be exposed to an event that involves actual or threatened death, serious injury, or sexual violation. And that exposure can happen by experiencing it yourself, witnessing it, learning that it occurred to someone close to you, or experiencing repeated exposure to trauma through your work. Now, some of the directly experienced traumatic events that we can think about as examples: exposure to war, either as a combatant or even as a civilian, threatened or actual physical assault, being physically attacked or robbed, mugged, childhood physical abuse, threatened or actual sexual violence, including alcohol or drug facilitated sexual assault, non-contact sexual abuse, sexual trafficking. Okay? Being kidnapped, being taken hostage, experiencing a terrorist attack, being tortured, being incarcerated as a prisoner of war, natural or even man-made disasters, severe car accidents. All of these things are potentially directly experienced events and is, again, not an exhaustive list. Now, for sexual violation, we should note that physical violence or injury is not a requirement. Okay, so that we're making sure that we're including, childhood sexual abuse where, there's grooming and there's not necessarily physical injury or physical violence, but this definitely still counts as a traumatic event. Okay. Now, witnessed events can include, observing someone, being seriously injured, or observing physical or sexual abuse of someone else, witnessing domestic violence, even witnessing a medical catastrophe like someone, having a life-threatening hemorrhage or something, right? Those can all be types of witnessed events. Indirect exposure through learning about an event remember, is limited to just people who are close to us, friends or close family members, and remember, has to be violent or accidental. Excuse me. And that can include things like the violent death of a loved one or suicide, right? A serious accident, and serious injury. So there's lots of different types of events that are included in this definition. And remember, what's that most important part? The most important part is the person's experience of it, right? If they experience it as threatening, then it can fit this definition of a traumatic event. Now, the next criterion B, outlines the potential intrusion symptoms. Okay? And trauma survivors need to experience at least one of these symptoms in order to have a diagnosis of PTSD. So the first potential symptom is recurrent, involuntary, intrusive recollections of the event. Okay, they're thinking about it when they don't want to, and it's unpleasant. Another common symptom is distressing dreams that either replay the event itself or that are representative or kind of thematically related to the major threats involved in the trauma. We may also see dissociative states that last from a few seconds to several hours, during which components of the event are relived, and the person believes the event is reoccurring or occurring at that moment. So they lose touch with the here and now reality and, kind of have a flashback, right? Now, these kinds of flashbacks can occur on a continuum. They can be very brief, visual or other kind of sensory intrusions about part of the trauma, to a complete loss of awareness of their present surroundings. Okay. And then finally, the intense psychological distress and the physiological reactivity often occurs in response to triggering events that resemble or in some ways symbolize an aspect of the trauma. For example, someone whose traumatic event was surviving a hurricane, maybe a windy day, right, will trigger that kind of intense psychological distress or physiological reactivity. Now, the next criterion, criterion C, we need one avoidance symptom for a diagnosis of PTSD. What we see here is that the survivor will make deliberate efforts to avoid thoughts, memories, feelings, or talking about the traumatic event. And they'll often utilize distraction kinds of techniques to avoid these kinds of internal reminders. Okay? They'll also avoid activities or objects or situations or people that serve as reminders of the trauma, as well as situations that feel more dangerous to them as a result of having experienced their trauma. So those kinds of situations aren't always directly related. For example, many people may avoid crowded places, right? That doesn't mean that their trauma occurred in a crowd, right? Instead, crowded places feel more dangerous to them now, likely because there's so much going on, so much to try to keep track of, right, and watch out for, that it feels very uncontrollable and very uncomfortable to them. Now, our next criterion, criterion D, details the negative changes in cognitions or mood that can be associated with the event or began or worsened after exposure to the trauma. So 2 symptoms are required here for diagnosis. Now, these negative changes can take various forms, including having trouble remembering an important aspect of the traumatic event. Usually this is due to more of like dissociative amnesia, not due to like a head injury or being drugged or intoxicated or something like that, right? In those instances, those parts of the memory were never encoded and so, are not going to be counted as something that the person doesn't remember. Another form is persistent, exaggerated, negative expectations regarding important aspects of life. For example, like I will always have bad judgment, I can't ever trust anyone again, okay? These kinds of expectations. People with PTSD may also have persistent, unhelpful thoughts about the causes of the traumatic event that lead them to blame themselves or other people that didn't cause it, right? So like, it's all my fault that my uncle abused me, for example. People with PTSD may also experience persistent negative mood states, even when they're not triggered by reminders of the trauma. So just, generally feeling more afraid, more angry, right? Even when you're not reminded of what happened. We may also see reduced interest or participation in previously enjoyed activities, feeling detached or estranged from other people, or persistent kind of inability to feel positive emotions, especially like happiness, joy, satisfaction, emotions that are associated with like intimacy or tenderness, with sexuality in some cases. Okay. So again, remember, we need 2 of those in order to qualify for a diagnosis of PTSD. And then the next criteria, and this is the last of the symptom criteria, this is the arousal and reactivity symptoms. And again, 2 are required here in this category for a diagnosis of PTSD. And here we might see that people are quick-tempered and may even engage in aggressive verbal or physical, behavior with no provocation, right? Maybe they're yelling at people, getting into fights, destroying things. Right? We may also see them engaging in like reckless or self-destructive behavior, like dangerous driving under the influence, excessive alcohol or drug use, self-injury, suicidal behavior. PTSD is also characterized by a heightened sensitivity to potential threat. So hypervigilance and this idea of like being on the lookout is also very common. You may also see that survivors are very reactive to unexpected things, like having a really big startle response or being very jumpy when there's loud noises or unexpected movements, sort of like jumping out of their skin almost in response to, like, let's say a telephone ringing unexpectedly, right? We also see concentration difficulties, including like difficulty remembering daily events, or trouble attending to tasks when you're trying to focus, trouble following a conversation for a sustained period of time, or being able to keep a storyline when a commercial or an ad comes on when they're watching something. These are commonly reported. And finally, the last symptom is related to problems with sleep onset and maintenance, right? Sometimes this is associated with nightmares or safety concerns while they're asleep, or can even be associated with kind of just the general like elevated arousal that they're experiencing 24/7 that can interfere with adequate sleep. Now, there are a few more criteria. The last 3 have to do with the amount of time the symptoms are experienced. 1 month is required for PTSD diagnosis. The impact of the symptoms, so they have to cause significant distress or impairment. And the cause of the symptoms, they have to be directly attributable to the trauma and not to something else like the effects of a substance or any kind of medical condition. The final considerations that we have for PTSD diagnosis are the diagnostic specifiers. Okay? So because some people will experience dissociative symptoms along with their PTSD symptoms, we can specify this. And this is broken up into 2 types. So one is what we call depersonalization, where the person has the experience of feeling detached from their own body or mind. And the other is derealization, where the person experiences episodes of feeling as if things around them are unreal. And then finally, we can specify if the person experienced a delayed expression of symptoms, meaning that their symptoms didn't manifest until 6 months or longer after the event, which happens from time to time. Sometimes people are so good at, kind of burying this that they don't really crop up for years and years later sometimes. Right? So that's what is required for a diagnosis of PTSD. And we actually have some information, some data that shows us that PTSD symptoms are very common in the immediate aftermath of a trauma. So this is actually data from a study we conducted here in Philly, where we assessed people within the first week of experiencing a trauma, and then at 1 month, 2 months, 3 months, 6 months, and 1 year post-trauma. And what we found was that almost all of the people we assessed, 87%, reported PTSD symptoms in that first week after they had their trauma. Now, gradually, as you can see here, the number of people who reported PTSD symptoms went down over time, even in the absence of treatment. So none of the people in this study received treatment or counseling for their symptoms. Okay, so we see that naturally, those PTSD symptoms went away on their own for a good amount of people. Okay. Now, thinking about that, right, you may remember that I said, PTSD isn't diagnosed until at least 1 month post-trauma. But here I was talking about, in the first week, people were reporting PTSD symptoms. So technically, those people reported PTSD symptoms, but wouldn't have had a diagnosis of PTSD. Instead, they would have been diagnosed with acute stress disorder, which is basically what we call those symptoms in the first month post-trauma. So it's important to remember that last slide, though, that we were looking at, right? Because not everyone who experiences trauma goes on to develop PTSD. Okay? We see that the rates go down over time on their own, which is important for us to remember, okay? Because it begs the question then, how does PTSD develop? Why are some people, getting stuck with these PTSD symptoms and some are recovering on their own? Now, this is where emotional processing theory comes into play, right? This is a theory that attempts to explain the development of those early PTSD symptoms, the recovery process, as well as the maintenance of PTSD symptoms. So it states that fear is represented in memory like a program for escaping danger. Okay? This program or fear structure contains all the information about the feared situation, about how we respond to the situation, and about the meanings of the feared situation in our responses. So when a fear is realistic, the fear structure contains appropriate information about how to respond to the situation. So let's use an example. Let's say we were all in an actual room together instead of a virtual Zoom meeting. And all of a sudden, a lion comes roaring into the room to attack. Okay, that's the feared situation. Now, each of our responses are going to be different. Some of us may run, some may freeze, some may hide, some may try to fend off the lion, amongst other things, right? Everybody's going to react differently. Okay. Now, after this kind of experience, we're all going to reflect on our responses in different ways. So a person who tried to fight off the lion may feel that, he or she was very brave and helped to protect people. A person who froze may feel that they were cowardly and, it's their fault that other people got harmed. Okay? So those are the meanings associated with the event. Now, the person who felt they protected others will have a realistic view of the situation, right? They'll say, a dangerous lion came in the room and I was competent and I helped to protect people. The person who froze is going to have an unrealistic view. They're going to say, a dangerous lion came in the room and I failed everyone there, and it's my fault that people got harmed. Now, for the person with the unrealistic beliefs about the situation, they want to ensure that something like this never happens again because they don't want to be responsible. They don't want to feel this guilt and blame. So they're constantly on the lookout for danger, constantly afraid, and start to see even harmless things like a lion in a zoo who cannot harm you as dangerous. For this person, any room full of people, since that's the situation the trauma occurred in, seems dangerous. Any photograph even of a lion evokes fear. So you can see that difference, right? That a photograph of a lion isn't going to be harmful to you, even if you experienced a lion attack. But those wires get crossed, right? Let me give you another example that's maybe a little bit more realistic. Here we see a story of a sexual assault that occurred to a former client of ours at the CTSA. Now, it doesn't look much like a story, but let me explain. We have these different pieces of the event that are included here that include a rape that occurred. So for this particular client, she lived in the suburbs of Philadelphia and had a window air conditioning unit in her home. And one night, a rapist took the window air conditioning out, broke into her home, held a gun to her head, and raped her. Okay? So we can see all of these things represented here, right? We see her. We see that she is alone at home in the suburbs, right? There's a man who threatens to shoot her with a gun, okay? He happens to be tall and bald, okay? And he rapes her. Now, what you see here is that there's two different kinds of lines. There's dotted lines and solid lines. The solid lines represent realistic associations, okay? So being threatened to be shot, right? Having a gun to your head, these are dangerous situations, right? Being raped is a dangerous situation. Those are realistic associations. The dotted lines, however, are unrealistic. So for this particular woman, she now feels that tall and bald men are dangerous. Okay? She now feels that her home in the suburbs is dangerous, that being alone is dangerous. Okay? These are unrealistic because they're not always true. Not every tall, bald man is dangerous, right? Her home had been safe for years until this event occurred. People are alone all the time and don't get assaulted or attacked. Okay? So these associations are unrealistic. So that's related to danger. On the other side, we have her reactions and what she did. So she at times froze, at times she felt confused, at times she screamed. At one point, he held the gun to her head and said, "Tell me you love me," and she did. She feels like all of these pieces of evidence are evidence that she's incompetent, right? Who would tell their rapist that they love them? What kind of an idiot would freeze, right? How, incompetent am I that I had this window air conditioning unit in the window to begin with, right? Even her later development of PTSD symptoms contributes to this idea that she is incompetent and this was all her fault. Okay. So we can see this story represented here, right? And we can see that this may be a reasonable way to think about things in the immediate aftermath, right? Again, those initial PTSD symptoms, right? It may make a whole lot of sense to be afraid of tall or bald men at first, right? But how does PTSD develop? Again, how do some people get rid of those dotted lines on their own, and some people remain, stuck with them for years and years? Well, when the trauma memory is activated by daily life activities, there are really two paths. So let's take this woman, right? And let's say she decided to continue to engage in the activities of daily life. So, she takes some time to recover, right? And then eventually she goes back home, right? Because let's say she stayed with her parents for a while. She goes back home to her house. She goes back to work, right? And as she engages in these daily life activities, she's reminded of the trauma, right? The house, her bedroom, reminds her. As she's walking down the street to work and she sees a tall, bald man, that reminds her, right? But she keeps doing it and she sees that no harm comes to her, right? People aren't breaking in the house every night, right? All tall, bald men aren't dangerous. They're not hurting her. And so she gathers the evidence for herself that these situations can actually be safe. She gets corrective information. And so those lines, right, start to fade away. Okay? She no longer has those unrealistic associations. Now, on the other hand, what we could see happen is that she sees these activities as extremely dangerous. And so she goes to stay with her parents and refuses to go back to her home alone at all. Okay? She tries to go to work, but the minute she sees a tall, bald man, she runs away in fear. Okay? And what happens is that, again, these kinds of daily activities are reminding her of the trauma, okay? But they're so overwhelming and so scary that she wants to avoid them, okay? So she stops doing all those things. And what does that avoidance do? Well, it keeps her from being able to change her beliefs, her thoughts, or her feelings about the trauma, and she ends up with PTSD. So when we continue to engage in the daily activities of life and see that no harm comes to us, we said those unrealistic associations go away, just like we see here. Okay. Now the realistic associations remain, right? And that's good. It is a good thing to be, to feel like guns are dangerous, and that, someone threatening to shoot you is dangerous, and that rape is dangerous. Those are associations we want to remain. Okay? And this, what we see here, is what happens in natural recovery. This is what happens actually for most people who experience trauma. But for the individuals who end up with PTSD, many of those are the ones that we serve, right? The folks without PTSD aren't coming in to see us. This is actually what we're trying to achieve. We're trying to mimic that process of natural recovery that they weren't able to engage in before for whatever reason, right? For whatever reason that they weren't able to continue to engage. So in order to make that happen, to mimic natural recovery, there are two requirements, really. First, we have to activate the emotional structure, that fear structure that we talked about. We need to access the fear and anxiety through doing something like talking about the trauma, right? Secondly, we need to ensure that corrective information will be available through seeing, for example, like that they could talk about the trauma without losing control. Now, prolonged exposure therapy is designed to create exactly these conditions. So prolonged exposure therapy, or PE, how does it work? What is it? Well, let's say we have a client who was attacked by a Rottweiler. He comes in for treatment because his fear has become so overwhelming. He's hardly leaving his house for fear of coming into contact with the dog. He tells his therapist about his experience and about how his fear has generalized from Rottweilers to, any big, scary looking dog, right? Now, in addition to having this person talk about the traumatic experience, the therapist knows that facing his fear of dogs themselves is going to be important. So he plans an in vivo or real life exposure to do with the patient. So he tells the patient, I'm going to bring a dog into session and we're going to work together on gradually approaching and being near the dog. Okay. He has a friend who just had some puppies and he thinks this is perfect, right? Because who could be afraid of an adorable little puppy? Right? So he brings the puppy into work and he's got the puppy in the session and he brings the client in and the client looks at the puppy and he says, what an adorable little puppy. This is awesome. How cute is this furry little guy? And the therapist says, well, aren't you afraid? You told me that you were afraid of dogs. You told me you're not leaving the house because you're afraid you're going to run into dogs. And the client says, well, yeah, but I'm afraid of big, scary looking dogs, right? I'm not afraid of puppies. So what happened there? The therapist didn't have that first requirement, right? Didn't access the fear, didn't bring up the fear and anxiety, okay? Because this person wasn't afraid of puppies, was afraid of big, scary dogs. So the therapist says, all right, I think I understand, that's my mistake. Next time I'll do better. And so he finds a friend who has a Rottweiler. And he thinks this is perfect. This is now I know this is going to access the fear, right? Because this is the exact kind of dog that he's afraid of. So he brings the Rottweiler into work, brings the client into the session. And as soon as the client sees the Rottweiler, you can visibly, he is anxious. He is afraid. Okay, so we've gotten that first point. We've accessed the fear structure. Okay, so we're on track. And they work together slowly, step by step, getting closer to the dog and closer to the dog, right? And then they finally get up close enough to the dog to where the dog can reach out and touch them, and the dog jumps and bites the client. Now, that's not good either, right? As you can all imagine. What happened there, right? Let's go back. We don't have corrective information, okay? What happened there is that the client only learned Rottweilers are really, truly dangerous. Look, everyone you encounter is going to attack you, okay? So we don't want either of these things when we're doing PE. What we want is, we don't want the cute little puppy, right? We do want a dog that's going to evoke the fear, right? But we don't want one who's going to attack us. We want one that's lovable and cuddly and is going to be sweet so that the client can learn that not all Rottweilers are going to harm him. Not all tall, bald men are going to rape you, right? And you can see how this can relate to all kinds of different trauma. Okay. So that's how PE works, what the mechanisms are. What is it exactly, though, you may be wondering? Well, PE is highly effective. Okay, we know this from more than 30 years and over 100 randomized clinical trials conducted all over the world. And it helps to reduce symptoms of PTSD as well as other related symptoms like depression and anger. It's flexible. Okay? It can be used to treat PTSD related to all types of trauma and for people with other diagnoses in addition to PTSD. It's also a gold standard best practice recommendation for many large oversight organizations like the American Psychological Association, the Department of Defense, the Veterans Administration, among others. Okay. So I'd actually like to show you a short video that nicely and kind of succinctly explains what PE is. This video is kind of like a cartoon. It was created by the VA as an educational tool for clients with PTSD who were considering treatment. So I think it's nice for us to kind of take a look at, sort of what this would look like, kind of coming from a client or, to a client's perspective. Okay. And of course, the video isn't going to work for me. Sorry. I practiced this so many times and the video worked every single time.
Sandy, what's the title of the video? I can try and Google the URL and put it in the chat.
I think I can actually grab it. Let me see if I can show it on. This is part of the reason why I have a backup computer. I'm gonna try and show it on here.
If you have post-traumatic stress disorder,
I'm gonna bet you can't hear. Sorry. 1 second. Here we go.
if you have post-traumatic stress disorder or PTSD, it's common to feel like there are places or situations that are unsafe. It may seem like the best option is to avoid them, staying away from people or places that feel dangerous or reminders of a traumatic event. As a result, you may develop I can't rules. I can't leave the house at night. I can't trust anyone. I can't handle crowds. But these rules won't help you overcome PTSD. So how do you learn to say I can? Prolonged exposure, or PE, is a treatment for PTSD that helps you do safe things you've been avoiding. In PE, you and your therapist will practice exposure, meaning you'll work to approach things you've steered clear of since the event. You have to challenge your I can't rules to prove to yourself that you can. Remember when you were learning to swim or even drive a car? It was challenging at first, but got easier with practice. Exposure gets easier with time. With your therapist, you'll take steps to do the things that have been hard for you at your own pace. So if you're avoiding the grocery store, you might start by going when it isn't crowded, maybe bringing a family member along. You'll eventually practice going on your own, perhaps even during peak hours. With practice, you'll find that you can handle it. You'll also talk through the details of your traumatic event in a safe, gradual way with your therapist. Closing your eyes can help you concentrate. Retelling the event may sound like the last thing you want to do, but it helps with emotions like anger, guilt, and sadness. You'll listen to a recorded version at home too. After a few months, you'll find that you can talk about your trauma without feeling so overwhelmed. Prolonged exposure doesn't erase your trauma, but it can help you keep your traumatic experience from getting in the way of living your life. PE doesn't require you to take any medications. With your therapist's help, you'll follow a step-by-step program for about 3 months. Most people who complete PE show noticeable improvement in their symptoms, and many no longer have PTSD. Prolonged exposure works well for both men and women, and it's evidence-based, which means PE has been proven to work in multiple research studies. If prolonged exposure sounds like it could be right for you, talk to your doctor about finding a PE provider, or visit the National Center for PTSD website at www.ptsd.va.gov to learn more about PE and other PTSD treatment options. No matter how long you've been living with PTSD, know that you can get better.
So I think that's a nice, kind of short video that, helps to explain, what prolonged exposure is. Okay. Let me go back to our slides here. And what we see in that clip is that it talks about the components of PE. And those components include in vivo exposure, so repeated and gradual in vivo exposure to safe situations that people are avoiding just because of their trauma-related fear. Okay. It also includes, is the video playing now on the screen? Of course. All right. Go to the next slide. Okay. Repeated and gradual exposure. Okay. And the other thing that you saw was repeated imaginal exposure. All right. So that's where, we're asking people to recount their trauma memory and process it by discussing their, kind of thoughts and beliefs about it. And then the other piece that, they maybe don't talk about as much there is psychoeducation pieces. So this is where, we provide rationale for the treatment program and for the procedures that we do. It's important to tell people what we're going to do and why we're going to be doing it, we believe, and also talking with them about common reactions to trauma, and teaching them also a breathing retraining technique. Okay. So let's talk a little bit about the PE initiative here in Philadelphia. So there have been a lot of work that's gone into creating this initiative, which started back in 2011 and includes the screening of individuals for PTSD. Okay, so since 2011, CBH and EPIC have partnered with us at the CTSA to sponsor the PE initiative. Okay. And in that time, what we've done is we've screened almost 12,000 people for the experience of trauma. So to see if they have had a trauma. And what we have found is that many people, so 60% or so, have experienced one or more traumatic events, and that 78% of those reported significant current PTSD symptoms. Okay. So that's more than 5,500 people who could potentially benefit from treatment for PTSD. So there's definitely a need in our Philadelphia community mental health centers, and PE meets that need, right? What we've seen in our outcome is, very good outcomes in people who've participated in PE. So here in this slide, we see that the average PTSD score for people who received PE was nearly 50 prior to treatment. Just for reference, the PDS-5 is a measure of PTSD symptoms, and the scores range from 0 to 80. Okay, so 50 is, kind of up in the severe range. So people started at a 50 or so, and after an average of almost 11 sessions, their scores decreased to an average of just about 23. So that is a 53.5% reduction in PTSD symptoms, which is amazing. Notably, too, the cutoff score for a diagnosis of PTSD on this measure is 28. So a score of 23 places them below that threshold, meaning a loss of diagnosis. So this is pretty impressive under any circumstances, I think. But when we're looking at just 11 sessions, too, right? Especially when so many people struggle with PTSD for years and years and years, these are amazing outcomes, right? So the other thing that I want to show you, the other video, which we'll see if this works, is a video that involves real people, not just drawings. So this is a segment that was done on a show called Al Jazeera America, and it profiles two clients. One is a client of mine who completed treatment a few years before this was taped, and one who was currently undergoing treatment with another therapist. So I think that this segment can give you an even better idea of what PE looks like in real life. So let me see if I can share here in a way that will be helpful. Any moment now.
Tonight goes in depth now with a dramatic and sometimes disturbing therapy for PTSD. Though it is hard to watch, it's therapy that offers new hope to young victims of sexual assault. A 5-year study finds the intense treatment, which has also been used to help combat soldiers, is also making a difference for rape victims, even very young ones. America Tonight correspondent Lori Jane Gleehow was given rare access to the usually private therapy sessions.
He's kissing the inside of my leg. It feels so weird. It sucks. I don't want him to touch me.
This is a type of therapy for rape victims.
Like goo. Horrible. Like I'm like laying in garbage.
It requires Tahira Stovall to repeatedly recount the horrific experience that left her wondering whether she'd live to see another day.
I feel like I'm like in major danger. Like if I try to even like that, I don't want him to touch me. Oh my God.
It may seem cruel at first glance.
Great job, Tahira. You can do this. I know it's hard.
In this video, she's 17 and remembering skipping school to hang out with her then boyfriend. He took her to his friend's house where another man she'd never met forced himself on her in a back room.
After the situation, I felt like it was my fault because I didn't fight. And I didn't want to, I didn't want to make it a big deal because I was like, I didn't fight back. Like, it's my fault. I should have fought. I should have did more.
Tahira had been an outgoing teenager, a dancer who loved school and snapping pictures with her friends until the trauma of her rape took over her life.
You feel like a walking zombie, like you're just walking through life and not even being able to look at my parents, not wanting to hug anyone. I couldn't even stand in a line, at a store, and somebody stand behind me, I was uncomfortable. I couldn't look at my dad because he had the same look that the guy had was the same look that my dad has.
What does that do in your heart to know that you couldn't look at your dad?
When I did look at him, I looked at him in disgust. It was hard.
She stopped dancing. And I mean, she danced. She lost her dance. She lost her joy. She just became like a shell. And I remember I used to tell her I wanted to see her dance because I knew that would somehow that's how she had to fight back. She needed to take her life back.
Everyday activities like going to school became almost impossible for Tahira. Her mother, Juanita Sojourner, never knew what could trigger an emotional breakdown. She eventually started homeschooling her daughter.
I wanted to protect her. I've always wanted to protect her. I felt like I had failed.
Tahira was diagnosed with post-traumatic stress disorder. She tried various types of therapy, but was still suffering. Juanita contacted a local rape crisis center where she met Dr. Sandy Capaldi, a clinical psychologist at the University of Pennsylvania, who recruited Tahira for a groundbreaking study of adolescent girls. Tahira would undergo a treatment called prolonged exposure therapy.
I feel like he's dirty, touching me. And I feel like I can't do anything from that point.
We have the adolescent tell the story of what happened to them repeatedly, over and over, throughout sessions.
It was kind of scary because I really didn't want to talk about it. I didn't want to acknowledge the fact that I went through it. I didn't want to acknowledge the fact that it was called rape. I don't think I wanted to close my eyes, Closing my eyes made it all too real. You pushed me down.
The therapy required Tahira to face her fears head on.
I didn't want to be in a room with the doors open at night. I really couldn't sleep.
Dr. Capaldi told her to sleep with her door open until it became less scary and to visit places that made her anxious, like the house where she was raped, not far from her own home.
Could you have done this walk without the therapy?
Probably not. I hated walking by myself.
If I can handle.
Prolonged exposure therapy was developed more than 2 decades ago by renowned psychologist Dr. Edna Foa. She regularly teaches her methods to doctors from around the world during seminars like this.
But we are going to push, gently.
It's widely used by the Department of Veterans Affairs for servicemen and women who suffer from PTSD. Research proves it's successful for most adults.
About 85% are being helped. But there are about, between 10 and 15% that are not helped. But we also know from studies that we've done that nobody got worse.
The study that Tahira was part of found it also helps teenagers. Published in the American Medical Association Journal, results show of the patients who received prolonged exposure therapy, 83% were cured of their PTSD diagnosis, compared with 54% who received traditional supportive counseling.
And I was outside, bent over a car, and he was having sex with me from behind.
America Tonight was allowed to observe this woman's ongoing therapy sessions. Typically, there can be as many as 16 sessions before a patient no longer has PTSD. We met her at the beginning of her treatment.
I don't know, I just get so uncomfortable.
Yeah. The patient asked us to protect her identity for safety reasons. She was a teenager when she was raped. She's now 21 years old. Dr. Emily Malkoon has been working with her to confront her trauma.
What do you think is going to be the hardest thing for her to overcome?
I think anger. She told me she has a very hard time letting herself feel angry with people. And I think also letting herself feel the emotions.
In her first session, this patient talks about her rape in a mechanical way.
He's just standing there, staring at me. And I'm just sort of in a panic, just saying no. No, my friends are out there, no.
Each time the patient repeats the story of her rape, her anxiety decreases. All her sessions are also recorded, and she has to listen to herself recounting her rape every day.
How hopeful are you that this patient will be successful with this type of treatment?
I am extremely hopeful. I can say I'm absolutely confident.
Several weeks later, we went back to observe another session. This time, Dr. Malkoon pushed the patient to reveal more graphic details about her rape.
I could physically hear it. I could hear the friction. I can hear him heavy breathing, and then I can just hear me being like pushed against this car.
The patient says it's getting easier, and she's learning to reconnect with her emotions.
Is there anything that you would say is not working for you in this type of therapy so far?
So far, to be very honest, like there's haven't been a negative feeling towards this therapy. I mean, obviously, there's a big source of big feeling of uncomfortableness that comes with this therapy, but that means it's working.
Where do you want to be ultimately?
Where do I want to be? I want to be emotionally stable, not just be controlled by my PTSD.
It's a freedom Tahira Stovall has achieved. Able to smile again and laugh and even dance.
She danced this thing. She took her life back. That thing, she took her life back.
And this move right here was just us like washing the shame off, washing the fear off, washing everything that I felt off, you know. And in this moment, I claim myself as not being a victim, but like I am a rape survivor.
That is a victory. America Tonight's Lori Jane Gliah here. Tell us how these young women are doing now.
Yeah, well, Tahira has been able to find a lot of healthy relationships since she started her therapy, and she's actually happily pregnant right now, and she's about to graduate from college, so she's doing really well with her therapy. And then the other woman who went through the therapy, she had a few sessions since we last saw her, so I just checked in today with her doctor, who said that she's doing amazing. When she started, she came in with a moderately severe level of PTSD and a clinically significant level of depression. But after 5 sessions, those have gone down so much that she's not even considered to meet the criteria for PTSD, and her depression has gone down by about 4 times. They say there's going to be a few more sessions to go. She's still dealing with some trauma issues, but it's been very successful for her as well.
And after only 5 sessions, now I have to ask, though, it seems like this is a fairly traumatic experience. Just, are there critics of it? Does anybody think it's a bad idea?
Yeah, well, we haven't been able to find a lot of vocal critics because there is so much evidence out there that shows that this type of therapy works. But still, there aren't a lot of doctors that are doing it yet. It requires some special training. They have to take classes to learn how to do this type of therapy. And also, there's been some arguments made that some therapists might find this a bit boring because it's the same thing over and over again, repeating the thing over and over again. And also, some of these doctors might not want to put their patient through this type of therapy because it does seem traumatic. It's supposed to be, you think of counseling as calming and soothing. But then again, if you avoid some of these issues, that's one of the things that contributes to PTSD lasting longer. So that's the argument to actually do this type of therapy.
And it isn't a first-line therapy. It's something that people have come to after trying other things.
Well, a lot of times, yeah, a lot of people have gone through other types of therapy too. So,
America Tonight's Lori Jane Gliah. Thanks very much.
All right, so that was, as I said, a short clip about, a couple of real people actually going through the treatment. And I think, it's nice to, see the progression, right? And to see, the difference between someone who has, gone through the process as well as someone who's in the middle of it, and, to see what life can be gained from actually dealing with and addressing, these PTSD symptoms. So, in summary, to kind of summarize what we've talked about today, right? Trauma can take lots of different shapes and forms. Some traumas are more likely to result in PTSD symptoms. And while everyone responds to trauma differently, some reactions are commonly and frequently observed among survivors. Remember, PTSD develops and is maintained by avoidance. And, accessing that trauma-related fear while at the same time providing corrective information can imitate that process of natural recovery from trauma. And PE is an effective and efficient treatment for PTSD and related symptoms that creates those circumstances to mimic that natural recovery process if the person wasn't able to do it in the immediate aftermath. Now, I know that there have been questions as we've been going through. Obviously, we can't answer all of them. Emily, I don't know if there are a few that you may have picked out that might be important to address.
Yeah, there's a few that are quick, so I'll throw those out first as I kind of comb through a little bit more. But the first is EMDR under the umbrella of PE, or are they two different types of exposure therapy?
There are two different types of therapy, and EMDR does not like to be categorized as an exposure therapy or even as a cognitive behavioral treatment. So they see themselves as separate from, either or both of those categories. I think that what is helpful and what works in EMDR is the exposure component. Again, even though they don't see themselves that way, I think the idea of asking, the client to talk about their trauma memories is, what is helpful about EMDR. So far, we don't know of any evidence that shows that the bilateral stimulation is, helpful or increases, the efficacy or effectiveness of the treatment. But they are two different, very different treatments.
And there was another one about if a person, I think just a clarifying question, if a person has to have an official diagnosis or if they just have PTSD symptoms, can they receive PE?
That's a great question. So we did talk a lot about PTSD diagnosis, right? But as clinicians, we're more concerned with treating symptoms. And so if a person has symptoms of PTSD that are interfering, distressing, impacting their lives, then we can certainly think about PE as a treatment option. So they don't need to have an official diagnosis if they miss a criterion, of those strict criteria that we went through. If they miss something here or there, we will likely still be okay.
Could you explain the difference between prolonged exposure and a more gradual systematic desensitization? I can't say the word desensitization.
So actually, PE grew out of systematic desensitization. Dr. Edna Foa, who I mentioned, is the developer of PE. She actually worked with Volpe, who is the developer of systematic desensitization. So she was one of his students. And the idea behind systematic desensitization is that if you do something that's anxiety provoking, but you pair it with something that is anti-anxiety, like relaxation or something like that, that you will be able to handle the exposure and you'll have success. In the research that was done over the years since systematic desensitization, it's a hard word to say, desensitization was developed, what was found was that that component of the relaxation or, that sort of opposing activity was not necessary. and that people had just as good, if not better, outcomes when they didn't do something like that. And so over the years, systematic desensitization has kind of dropped by the wayside in favor of full-on exposure.
There are a couple more. I think we'll try and do two more.
Sure.
So one looks like it's, is it appropriate to remind the client that avoidance is one of the main contributor to the trauma and use that as encouragement during treatment?
Absolutely. So with PE, we are very transparent about our thinking process behind it. And remember, I said that we, will provide rationales. So our rationale is, basically that avoidance is maintaining their PTSD symptoms. And so approaching the things that they're avoiding can help to undo those symptoms. So we definitely will talk with them, with clients about that repeatedly, throughout, while we're preparing them for treatment, while we're doing treatment. And, we'll have to kind of keep coming back to that idea because avoidance is very seductive. It usually results in the immediate reduction of anxiety, which feels good. And what we're saying instead is, we're going to do something that's going to be a little bit uncomfortable for a while until we get used to it to overcome that fear.
And then the last one, I think you're going to like this question, Sandy, but someone asked why prolonged, and earlier in the chat had said prolonged sounds as if it can be overwhelming exposure to the extent an individual can tolerate it appears to be better suited to gradually desensitize. And I think this kind of goes along with people wondering if PE re-traumatizes clients.
It's funny, if you ask Dr. Foa about it, she will say that she regrets calling it prolonged exposure because it does sound scary, that she would prefer if she had her, wishes to call it emotional processing therapy. But it's already so, ingrained, 30 years of, research and publications and all of that, it's too hard to change now. And originally the idea was that the person needed to engage with this material for a prolonged enough period of time to see habituation occur, to see that it got easier for them. So if they approached something and they felt like it was scary and they escaped, right, they wouldn't learn, they wouldn't get that corrective information. So they had to stay in the situation for a prolonged period of time. So I think that's where that idea came from. And Emily, I lost, was there a second part of the question? I lost it.
Just about re-traumatization. Is there a risk or a fear of re-traumatizing clients?
That's always an interesting question to me because I'm not sure exactly what re-traumatization means, right? When we're talking about trauma as a threat, right? Serious injury, death, right? And sexual violation, that is certainly not occurring in any therapy room, right? That I've ever seen. And so one of the things that we're actually trying to do in PE is get our clients to see that thinking about, talking about what happened to them is actually very different than having been traumatized. That the actual situation was harmful and, terrible and awful and all of those things, but that talking about it cannot harm them. It cannot invade their body. Right. And so seeing that distinction is a big part of the treatment process as well.
Well, that was the last question. Thank you, Sandy. This has been excellent. I'll make sure to send you the chat so you can view the comments afterwards. A lot of grateful chats. And hopefully this training was very useful for everyone. And sorry, I'm trying to do two things at once. I'm never good at that.
And thank you all for your attention. It's been great.
Thank you.
So just a little bit of information. I'm about to put the evaluation. This should be the evaluation link. Oops. And this will be emailed out as well. I see a bunch of chats coming in, so the evaluation link quickly disappeared. I'll send it again. But I'm going to email everyone the eval and the post test. Remember, you have 7 days to complete. And then BH10 will email out the CEUs afterwards. So just make sure when you put in your email that it's correct. And if you have any trouble, don't hesitate to reach out to myself. My information will be in the email, and I'm happy to kind of work with BH10 around any questions that you might have. So once again, thank you so much, Sandy. That 90 minutes went by so fast. I don't know how it felt on your end, but this was a wonderful training, and it was wonderful to have you all.
Thank you.
Thank you, everyone.
Bye.
Thank you very much.
Yeah, you can refresh and have a